Hey, Gestalt Education Nation. New sponsor alert. Today, we're excited to announce Dynamic Disc Designs and Jerome Fryer. We have an awesome discount code for you. Just use the code Gestalt to get a little bit of money off on the Dynamic Disc Designs. They're the most realistic anatomical discs that we've ever seen. If you caught our episode with Dr. Stuart McGill, you saw an entire shelf full of them. Everything from cavitation instruction to disc dysfunction to SI joint dysfunction, all sorts of amazing
joint
stuff.
movement,
Yes,
vertebral movement.
Absolutely. So go to Dynamic Disc Designs, use the code Gestalt. As always, you can use the code Gestalt on Core 360 belt to get a little discount on the belts there. We love to use that for biofeedback for teaching respiration, intra-abdominal pressure, and how the abdominal wall should be working during function. And then the last one, use the code Gestalt Education 10. Those will all be in the description in the podcast. Gestalt Education 10 at humanlocomotion.com to get off some money off of all of his awesome gadgets and tools and rehab materials. What's your favorite, Brett?
He's got a trunk full, but I think, integrating the Toe Pro in, I think, has been a game changer for us here at the office. So I think that would be my pick.
Beautiful. All right, guys, don't forget, use the code Gestalt, Gestalt Education 10. Visit the show notes and you'll be hooked up. Thanks. Enjoy the episode. All right, everyone. Welcome to another episode of the Gestalt Education Show. Today we are sitting down with our basically our mule. I don't know. We're just riding. We're just riding him to the promised land at this point. So,
well, I thank you.
Yeah. Dr. Tom Michaud. I mean, he honestly started off our podcast. He was probably one of our first 10 maybe,
and
when
honestly,
we went to Boston.
It's always one of our, everybody always says who's our favorite, and he always cracks the top three.
Yeah. So anyway, we're here in Raleigh, North Carolina. This is actually Lindsay Muma's treatment room. So if you see anything in the periphery that's kind of
if you see dream catchers, it's very, very hippie-ish in a good way.
Yeah. That's just par for the course for her, and we love her for it. So anyway, today we have two main topics that we're going to talk about. So Tom, you kind of published a paper, and you've read some research, and you actually have a new kind of gadget or device to add to your library about helping to decrease fall risks in our geriatric patients. But then there's also some application with lateral ankle sprains, and then there's also the new kind of obsession with yours, some new research on Achilles tendon. Yeah. So let's just start with if you haven't seen it, these peel and stick balance buttons, we're going to call them. So,
I love that name.
Balance buttons. So you should love them. You came up with it, right?
Well, my wife comes up with the name, so it's catchy. You can remember it. Like, I teased her when she came up with Toe Pro, and it ended up being a really clever name that people can remember. But yeah, it's nice. I like it.
The genius behind
without a doubt. Yeah,
so,
exactly. I'm just the mule that sits back and writes papers. And
you can come out now.
Well, we had to put a shameless plug in. If you use the code Gestalt Education 10, you get 10% off all of the humanlocomotion.com stuff. So there you go. He doesn't need any more damn money. So use the code. That way he doesn't know. I'm just joking. So where did this all come from? Where did you come up with these balance buttons?
Well, textured insoles have been around for about 20 years now. The theory is that if you have a textured insole, it stimulates cutaneous receptors on the bottom of the foot. About 10 years ago, a manufacturer asked me to help them make some textured insoles, and pretty much a lot of people know it, but you have 4 different types of cutaneous receptors. Some are slow adapting, some are fast adapting, Meissner's, Merkel, Ruffini, and one of the things about these cutaneous receptors is that I originally felt like you don't really need to focus on cutaneous receptors because muscle spindles tell you where you are in space, and I thought the cutaneous receptors were kind of over-amplified. And then I found some great research showing that your body relies more heavily on cutaneous receptors on the bottom of the foot to find out where your center of pressure is than spindles, because you don't realize it, but most falls don't happen while you're walking and your joints are giving you a lot of proprioceptive information. They happen at the initiation of gait. So people are standing still and you don't realize it, but the initiation of gait, where you take that first step, is incredibly complicated. Your central nervous system keeps you on the verge of a fall by firing mostly your medial gastroc, more so than your lateral gastroc. So if you picture that veal forward lean, or you feel like standing still, arms locked, pelvis locked, lean forward, your medial gastroc pulls you back so you don't have to use energy and you stay on the verge of a fall. That's why medial gastroc is tighter than lateral gastroc. That's why releasing medial gastroc surgically produces huge increases in ankle dorsiflexion. So when I saw some of the data that showed when people fall, it's because, and I talked about it with the Toe Pro, that when you begin your initiation of gait, your toes push down to control your anterior fall envelope, but your center of pressure travels along a path that is telling you where you are in space, and that causes specific muscles to fire. And there was some great research that showed that when the pressure was on the lateral side of your foot, it stimulated the peroneals to fire. It caused a change in your transition to shift you towards more of a medial displacement. And a paper came out not too long ago that showed the worst falls in the world, because 40% of people over the age of 70 fall annually, like 60 or 70% of people over the age of 85 fall annually, and those falls begin a downward spiral of deconditioning that is just horrific. So they published a paper showing that most falls, when you initiate gait, your central nervous system inhibits your gastroc to allow you to initiate a forward fall, and then sends a signal to your toes to control that fall. But if the center pressure accidentally goes too far to the side, you have a lateral fall that can't be compensated for. Like if you fall medially, if you're standing on your left foot and you fall to the right side, your right foot is there to catch you. If you start to fall forward, your toes are there to catch you, or you bring the opposite foot forward to catch you. If you fall laterally, it requires this complex crossover pattern that people can't do. Almost all hip fractures are the result of lateral falls. And this beautiful paper came out with microneurography, where this researcher checked the location with fine needle EMGs and special devices to show that almost all of your receptors are located along the lateral side of the foot with the highest density of both slow and fast adapting receptors beneath the cuboid. So it fit with, the Babinski response. You don't run, if you're doing a Babinski response, you don't run the reflex hammer on the medial side of the foot. It wouldn't do a thing. You run it along the lateral side of the foot, and the toes plantar flex and become more powerful. And then I thought of research by Robbins in the late, Hannon and Robbins in the late 90s, showing that if you stimulated the medial side of the arch, you actually inhibited that response and caused toe weakness, which would limit the storage and return of energy. And once I saw that lateral falls happen because they lose sensation on that lateral side, once you pass the age of 50, you lose 30% of your cutaneous receptors. By the time you're 70, you've lost 60%. It takes 70% more pressure, 60 to 70% more pressure to stimulate the limited number of receptors. So when you're walking and you're not getting enough data from those cutaneous receptors, you're going to fall because your spindles aren't going through a big range of motion. Your subtalar joint's not pronating. Your ankle's not dorsiflexing. It's all subtle motions. Vestibular centers don't control you. Eyes don't control you because you're not moving that much. So it's that fraction of a section where you go forward. So I originally tried to prevent falls in the elderly by strengthening toes, which Karen Michaud out of Australia showed you get huge reductions in fall rate, but that's anterior falls. Lateral falls, nothing protects you against. So when I saw the research on the locations, and on the site I put up a couple of illustrations that show exactly where they are, I experimented with different ways because the research on textured insoles has never been that impressive. Some research showed that it lessened falls. Other research showed that it actually increased the rate of falls because it produced pain. So I started out with silicone materials. And the materials that I liked the most were these small elevations, these small rounded elevations, 8 millimeter in diameter, about 6 millimeters high. I thought, because with the ones that I originally made, I noticed my fast adapting cutaneous receptors, within 5 minutes, I didn't even notice they were in there. I used small triangles. I used some of the other shapes. So I thought it has to be something that you don't adapt to.
Right.
So I made progressively larger. You don't have your center of pressure on the lateral side unless you've made a mistake. So I made some small receptors under the center. So each time your foot hit the ground, you felt a little. But then I made large ones that I actually hang off the side of an insole. And it's this, it's a cuboid. It's like a scaphoid pad. It's 2.5 inches by an inch. It's small. You, as peel and stick back, you just put it beneath the cuboid at the base of the fifth. And those large receptors, you don't feel unless you get near there. So you don't have time to adapt. So even the fast adapting receptors, Meissner's corpuscles, they will tell you you're here. And this great paper showed that once you stimulate those, peroneus brevis brings you back to a midline position. So I thought, well, I always wanted to make valgus post to prevent lateral falls, because if you raise the lateral side, you can lock the calcaneocuboid joint so that you can push off. So I made it a little bit thicker, so it acted like a kind of a valgus post beneath the cuboid to shift you. So your cuboid locking mechanism, you know that dorsal border of the calcaneus gets locked against the cuboid. I locked the cuboid by lifting there specifically. And then I changed the durometer. I changed the firmness of it. I started out with like such a firm material, my foot was bruised. That's why it caused, some of them, the research was inconsistent.
But you didn't fall laterally.
But it was hard even walking. So I just kept changing the durometer. Then I thought they'd compress too much, but I ended up with this one particular durometer, short A, where as long as you don't hit that lateral side too much, it stays there for months and months and months.
Are these normal age-related changes? Or are these a product of polyneuropathy, stenosis?
Normal age-related.
Normal age.
Great question. But with peripheral neuropathy, they completely lose sensation. And a PT that I met at one of your seminars specializes in chemotherapy-induced peripheral neuropathies. And I said a bunch to her because I don't have a lot of experience with peripheral neuropathies. And she sent me a really nice note saying that some of her worst clients claim they can feel it. And the reason for that is you're not just feeling the cutaneous receptors. Because it lifts the cuboid, you're feeling the articular receptors, because that confuses people. I had a surgeon years ago, I had a patient who was a dancer who had lateral foot pain, and the surgeon cut her sural nerve, and she still continued to have pain. And they did a block and it helped her a little. And I said, that's because the cutaneous receptors were blocked, but you still have the joint capsule beneath it. So that's why I wanted kind of a valgus post in there to lock the cuboid and stimulate both cutaneous receptors and joint receptors by moving the cuboid.
Shout out to Gabby Miller. I think that's who you're talking
She's
about.
She's amazing.
Yeah.
She's been really helpful.
Yeah.
And that's her specialty. She's writing a book on it now. I can't wait for her to finish it. And it's going to be really good because she does other interventions. She does nutritional stuff.
Sure.
Yeah.
Sure. And then is this, can you just make a broad claim and say once you reach a certain age, should these just be implemented in every single case? Or is there certain indicators that say, no, these are the patient population?
What I've been doing with it, because I don't think that people age chronologically the same. Yeah. Like someone who's 70 who's been a lifelong exerciser is probably going to have better cutaneous receptors. So I do that 10-second balance test, which is super easy. We talked about it before. They did a 12-year study, 1,700 people, and they said, with your eyes open, stand on one foot for 10 seconds. You get 3 tries. The people who couldn't do it had like an 85% increased mortality over that 12-year study. And the authors of the study said checking balance is more important than checking blood pressure, cholesterol, anything. A super easy test to do. If you're young and healthy, you think that's not hard, but do it on someone who's 70 or 60. You'll be surprised. If you've lost 60% of your cutaneous receptors, you don't know where you are. So you start to sway. And eyes open, a significant percent of the population can't do that. So if they fail that, everybody should do that 10-second test on anybody over 50.
Mm-hmm. And then do you feel like it's as simple as just giving them one-legged balance exercises? Is it that simple?
No, it's not that simple because it's, as you know, with DNS, it's reaction times.
Right.
It's incorporating sensory information to motor information. So I'll put that cutaneous receptor in the balance. What's the name of it again? The balance button.
The balance buttons, yeah.
Call your wife.
Yeah, call your wife, damn it.
To stimulate the receptors. But then I also will give toe strengthening stuff, and falls are very likely to happen as people reach for stuff. So that toe pro platform where your foot is on the ground, you get 4 times the strength gains when the toes are dorsiflexed, and you just lean forward, you increase that anterior fall envelope. For people who are fall risk, I have them take a 5-pound weight, and they've studied where you use 5 pounds, 10 pounds or more. 5 pounds is the key number. You lean forward, transfer it from one hand to another, because a common problem with falls, it's when you're in a grocery store, you grab a bag, you lean forward, you think you can control your anterior fall envelope, but you have a lever arm to the weight in your hand that amplifies the force on your toes. And when you can't match it, you go down. So you get them near a wall and you hold like this. That's why I wanted to come to this TNS seminar, because a significant percent of fallers, like I said, 70%, 40% of people over 70 fall. a significant percentage of them, especially when they're 80, they're called long lies. They can't get up. So some of the DNS patterns that you do, I wanted to incorporate into people in their 50s and 60s so that they don't become one of those long liars.
Right.
You can spend days, if you live by yourself and you fall, you fracture your hip.
Remember the commercial? I've fallen and I can't.
Yeah. You can go, dehydration's an issue, and it's just like a horrible thing. And if you can control that, so I want to look at toe strength, I want to look at, because the balance buttons, any cutaneous receptor only works while it's under there. Whereas toe strength works constant. You change the structure. Every 1% increasing strength beneath the great toe decreases fall risk 7%. That's a huge number. And you can quantify that number with that little dynamometer. It takes 2 seconds to do. You can just take out their insole and look at it. If they have like a big wear pattern under the central metatarsal heads, but nothing under the toes, they're high risk for falling. And all you got to do is pull that insole out. It's super easy to do. And the exercises are easy, lateral step ups to get, because quad weakness also predicts falls. Decreased neck mobility predicts falls. So I want to do a whole thing, increase thoracic mobility. Hilton Menz did a great study where he's like a great researcher. He was the editor of Foot Ankle International for a long time, and his specialty is fall prevention. And he put accelerometers on people's head and then measured head motions. And he showed that the thoracic spine works to absorb movement so your head stays relatively still in space while you're walking. And failure of this thoracic spine to dampen head oscillations alters your visual field and increases the risk of falling while you're walking. So like strengthen toes to improve that transition with the initiation of gait. And then increase the core strength. Lack of core strength predicts falls too. So I'm looking up everything that correlates with a fall, and I want to come up with quick, easy ways to change it that anyone can do. Like make it like a 6-minute program, because it doesn't take a lot to change tone. And balance. One of my favorite balance tools is just that Michaud protocol. You get a foam pad. I got a bunch of them coming in that I had manufactured. It's like 12 inches long, 4 inches wide. Eyes open, stand on it 1 foot, 5 minutes. And it seems like it's nothing, but and most people couldn't do it 5 minutes, especially if they're over 50. Within a minute and a half, you feel your glute medius trying to figure out what's going on with your center of mass. You start to get a burn in your hip abductors to control that subtle motion. And it takes information out of the cutaneous receptors because it's a foam pad. That was that study. They took all these football players who were high risk, high BMI, prior history of ankle sprain, decreased the rate of re-injury by almost 80%, high 70%, with that simple protocol. And they do it with their shoes on. It couldn't be easier. And I love that protocol.
Well, I mean, it takes us to our next piece, which would be the lateral ankle sprain piece. You know, over the years that they've tried all these other things like attachments on the outside of shoes to maybe control eversion. They've had all these things. Where do you feel like these balance buttons are playing into like recurrent lateral ankle sprains?
I love that, because a couple of years ago they showed that people with lateral ankle sprains, one of the best predictors is not the degree of ligamentous damage on MRs. It has no correlation with injury. You take a cotton swab or light touch. If they cannot feel sensation equally at their sinus tarsi, just below the lateral malleolus, that's predictive of ankle injury. And then manual therapy enhances that. And you can, like, I'll use Semmes-Weinstein monofilaments, so I can, and Gabby uses Semmes-Weinstein monofilaments to quantify sensory loss. You do ankle mobilization, ankle manipulation, immediate improvements in that, and it's measurable over time. So I will, really good paper when I wrote Human Locomotion, it's when I came across it. They showed that with proprioceptive exercises, if you put just a piece of kinesio tape that's not done, you don't do anything special with it, it just runs along the lower 6 inches of the fibula and goes under the foot, it sped up the return of proprioception 50%. And it was just because as the foot inverts, it pulls on the skin, so you get that sensation. These things do the same thing without having to put the strap on, because you don't feel it until that foot inverts. So once that foot's inverted, you'll either pull on the skin with kinesio tape, or you'll feel your Meissner's corpuscles, which are fast adapting, saying, hey, you just loaded the cuboid. And that produces peroneus brevis activity, which brings you back to the midline. So I don't use these things on young people because they showed that young people don't respond to textured insoles. And this was a great paper that came out that I loved. They used transcranial magnetic resonance, and they looked at young people and old people as they walked to see what parts of their brainstem and brain were involved in balance. And then they used textured insoles to see how it changed it. And they showed that older people use more of their cortex. They use more of the upper components of the central nervous system, whereas young people use that mesencephalic locomotor system. They use their brainstem because everything's automatic. So when their foot hits a certain spot, you don't have time for your cortex to say, hey, I think you're over here. You don't have time for your cerebellum to say, oh, we've got a problem. It's just in and out. Mm-hmm. So what they showed was that when they took the older people and they put the textured insoles in there, that there was decreased activity in their cortex and it became more of a spinal loop. No change in the young people. They stayed in the same pattern. That's why when you ask, who do you use it for? I don't use it on young people with good balance. I use it on older people with poor balance or younger people. If you can't do a single leg balance test, you're in trouble. And the research on balance buttons or textured insoles, they only work when you're wearing them, which is the downside of them.
Do you worry about any other structural foot pathologies that you've already noticed, or you just kind of blanket, we'll put that in, or it doesn't really matter as far as the structure of the foot and things like that?
Yeah, the biomechanics of the foot don't matter too much to me because overpronators tend to shift away from the lateral side. People with different foot types get injured for different reasons. People who have cavalivarus high arched feet, they get injured because they have less cutaneous contact with the ground.
Yeah, less surface.
So, but overpronators get injured because they have altered moment arms that they can't fight against. So as that talus adducts and plantar flexes, it pulls the tibia with it. Now tib posterior, it's not balanced like two pieces of wood on top of each other. Once you pass a certain lever, you can't come back to it. In order to maintain balance, you want to have like a structure where one section where the distal leg is on top of and stays centralized over the calcaneus. If it goes too far to one side, you can't move or use it
it's
anymore.
It's like taking a towel and eccentrically just lengthen it. Yeah.
It's not an option where it can spring back from that. Mm-hmm. So to stay balanced, you have to stay, the lower leg has to stay balanced on the subtalar joint.
How do you get buy-in or compliance of the patient? Are you telling them about the fall risk, or because humans are not very good unless they've actually had a fall or a problem of making some drastic change?
Great question. And what I do with this, I put it in their shoe. I do that test, check your balance. Then I put it in their shoe and I say, now check your balance. And it improves immediately. And that in and of itself is really nice. That's why these are new. I'm trying to get them studied. I don't know how well they're going to work. I've tested them on people between the age of 60 and 65 and 70, myself and my wife. And so far they've been working really great. But
have 12 beers and then
I don't know about that.
What a great control group that is, man.
Yeah, it's been working well, and I've given it, like Gabby gave it to peripheral. Anyone who specializes in like ankle injuries, I've been doing. I gave it to a couple of elite athletes that had a history of ankle sprains, and one woman tells me that her foot feels more centralized when it's on it. I'm just trying to get feedback now because it's only a few months old.
Yeah, I got to get some.
I'll send them to you.
Yeah. Sorry to interrupt your episode, guys. I have to tell you about an important date to write down in your calendar, November 3rd through the 5th, the first annual Neurodynamics World Congress coming to you at Parker University in Dallas, Texas, November 3rd through the 5th. This is an amazing opportunity to see a true Gestalt weekend, meaning integration of multiple different people, multiple different techniques of the likes of Michael Leahy, Antonio Stecco, Brett Winchester talking about DNS, Annie O'Connor talking about pain classification mechanisms, David Seaming talking about the internal chemistry, Jeff Bove talking about the research around nerves, and of course Michael Shacklock talking about neurodynamics. This weekend at Parker University, November 3rd through the 5th is your opportunity to see not only lectures, but hands-on demonstrations and panel discussions at the end of every day to combine this all together to show how each of these different techniques is influencing the nervous system. This is an amazing opportunity to see all these people in one stage and one opportunity to have some fun with us in Gestalt education. So thanks for taking the time to listen to this episode, and we can't wait to see you at Park University. It's November 3rd through the 5th. Registration open at gestaltedu.com/courses. See you there.
Yeah.
We gotta get some start messing around them. Well, let's transition a little bit to this new Achilles tendinopathy research. And so, Brett, you tell the great story about how all this kind of happened or how it started, right? The orthopedic surgeon, he was looking for a way to get his Achilles tendon.
He tried to tear he went on a crusade to tear his own Achilles tendon, and he actually healed himself by ballistically doing one-leg jumps on that's Alfredson. So so he came up obviously with the Alfredson protocol, which is pretty remedial. It's 3 times a day, 15 reps. And we've all talked before on previous podcasts where for a lot of our athletes and runners, that's probably just not enough load for what they're used to. In your older non-active patient, that might be exactly what they need. But for a lot of the people that, we're all seeing as far as the active community, it's just not enough load.
Right. And they showed with elite athletes, the Alfredson protocol didn't work at all. And then there was some data showing the 4 sets of 80, which I'd written about, stimulates tendon remodeling in elite athletes. But a 5-year study on the Alfredson protocol just recently came out, and they showed that 60% of people 5 years later who were consistent with it still had symptoms. So researchers then started saying, what works about exercise intervention for managing Achilles injuries? Because clearly it works. They have better short-term outcomes. They have better function. But what stimulates tendon remodeling? And everybody always thought it was just eccentrics, because they originally thought that an eccentric contraction, because there's titans on muscles, and when an eccentric contraction happens, it's like a ratchet where the muscle lets go, and there's a slight vibration associated with that. They thought the vibration stimulated tenocytes to stimulate repair. And then when the Alfredson protocol kind of failed for long-term people, researchers said there must be some other mechanism. And I found a paper that showed that fluid pressure dynamics plays a huge role in it. That people with healthy Achilles tendons, when they exercise, they decrease in diameter 13%. And the reason for that is the force output associated with the exercise pushes fluid away from the core of the tendon. And as that fluid is being pushed, it stimulates tenocytes to remodel. So researchers said, what is the exercise that is most likely to stimulate a change in intratendinous fluid pressure? And what they showed was they looked at short duration exercises, low load exercises with high reps, and they showed that only heavy resistance, prolonged isometric contractions stimulated fluid flow out of the core of the tendon, 13%. And that stimulates remodeling.
Is it worth differentiating between insertional versus mid-substance, or do you feel like that's not?
That is absolutely worth differentiating, because most of this research refers to non-insertionals, and they're now showing that as you go down the Achilles tendon, it changes structure from being highly flexible to being like a rigid fibrocartilage by the time you get to the attachment. And this is what we talked about last night, that everybody always thought as medial and lateral gastroc come down and soleus come down, they blend with the Achilles tendon, and then as a unit, they rotate 90 degrees so the tendon can store and return energy. And what they showed was fibers from the medial gastroc only rotate 85 degrees, fibers from lateral gastroc 135, 140, soleus even more. So there's this differential spinning. And when I saw
you got to draw a new picture.
I have them on my computer to draw. If I wasn't here this weekend, that's what I would be doing. It's funny you said that. So that means that the straighter attachment of medial gastroc allows it to put a force in at a quicker rate. So when you're balancing, we were talking about forward falls, that your entire gastroc does not work when you're standing still to prevent a fall. Only medial gastroc does. And it's because after I saw that, I didn't understand why there would be a differentiation between the two. It has a straighter line of attachment. So when it fires, it pulls you right back. When the lateral gastroc fires, because it rotates 150 degrees, there's a delay. So the lateral gastroc is more of a shock absorber. And you had talked about insertionals. The lateral gastroc, when you look at that rotation, insertional tendinopathies happen at the anterior aspect of the calcaneus. And now research out of Chapel Hill 10 years ago showed that when you're running, as your ankle is dorsiflexed, as you go into your push-off phase, the posterior aspect of the tendon attachment is under tremendous load. The anterior attachment is under no load. Like I tell people, if you have a rope and you put it in concrete, if you pull it to one side, the side away from you is going to be under great load, but the inside isn't. And they showed supraspinatus, when you abduct your arm, it doesn't tear at the high stress part. It tears at the low stress part, and they called it tension shielding. And they said these tendons are kind of accidentally made up so that certain components of it aren't under equal load, and that's the reason they break down. And then they did exercises only with the ankle plantar flexed. And when I saw this research and I saw the rotation of the lateral gastroc, it attaches to the anterior component. And this Francois Hug, a researcher from France, showed that the medial gastroc in a small subset of the population produces 8 times more activity than any fibers of the lateral gastroc. So if lateral gastroc is not firing, the anterior aspect of the tendon, no matter what exercise you're doing, is not going to be stimulated. So you could be doing like the classic insertional protocol where your feet are plantar flexion and go beyond neutral, and you're not going to be firing that anterior aspect unless you do something to stimulate lateral gastroc. Because if you think about it, there's 200,000 muscle fibers in your gastroc and soleus. They blend with 200,000 tendon fibrils so that they're continuous. Activity generated in the medial gastroc gets put into the medial component, the medial gastroc's tendon fibers. So if lateral gastroc isn't firing, its subcomponents that run through the tendon aren't firing, and the attachment point will break down. So I looked up exercises that have been shown to stimulate lateral gastroc. Toe-in straight leg stimulates lateral gastroc preferentially over medial gastroc. So every insertional tendinopathy now, I have them do like standard protocols, but I have them do that exercise where they do toe-in, bent knee. And this was some other great research because I said the soleus also attaches there. The soleus is far and away the largest muscle, and the calf generates significantly more force than any other muscle. And its weakness of it predicts Achilles injuries. And a researcher from Australia showed that soleus injuries are problematic because there's a delay in its firing. So if it doesn't fire in time, then you're going to get a failure of interfascicular movement. So remember I said muscle fibers blend with tendon fibers? And like I use the analogy, if you had like a handful of uncooked spaghetti and you just kept pushing on the same portions of it, it's called interfascicular sliding. That these 200,000 tendon fibers and fibrils all glide against each other. And they showed that people with Achilles tendinopathy have a tendency to use the same small subset of those tendon fibers. So other sections, like the lateral gastroc component and soleus component, they're not gliding. And they showed that as one tendon glides over another, and now they can look at that with ultrasonography, as one tendon glides over another, it creates a mechanical stimulus where the tenocyte says, you're using us. We need to get stronger. Just like weight training tells your sarcomeres or your satellite cells to say, repair this muscle. So they said, since intratendinous sliding is so important, because people with healthy Achilles tendons have huge variation in which tendon fibers, like a marionette, which tendon fibers are firing, but people with tendinopathy, especially after they've had surgical repair, just have this similar pattern where the same fibers are going. Because they can study that now, these researchers said, we'll give people all these different exercises, and then we'll watch what creates the greatest variation in fascicle sliding, because that would stimulate repair. And they showed that a bent knee heel raise, where you drop through a full range of motion, then raise up, it stimulated more fascicular sliding than any other exercise. And the authors of it seemed surprised by that, and I wasn't, because that fires soleus, and soleus weakness predicts Achilles tendinopathy. And another 2 papers I found showed that lateral gastroc weakness predicts Achilles tendinopathy. So
I think that might also be an explanation. I mean, if you work with athletes enough, you'll see, when they feel like that distinct pop and you rule out an Achilles tear, and they actually like release some fibers like right at that interface of the medial gastroc and the Achilles tendon. We've all seen it. Yeah. You never see that on the lateral side. It's always a medial
That's the straight fibers. When I saw that, I was like, because I never got that. I never got why it's always medial gastroc.
Right.
And also why when they treat plantar fasciitis, when they do a fasciotomy and they just cut the medial gastroc where it joins the tendon, the fascia, long-term resolution of plantar fascial injuries with that approach. And I thought, why just that component? And I lectured on it, I talked about it. That one little spot, it's this, size of a quarter, is responsible for most plantar fascial cases. And when I saw that section of the medial gastroc doesn't rotate, I thought that's the reason. And it's under more stress, it generates more force. And then I was wondering, I was using muscle oxygenation to measure activity in medial gastroc and lateral gastroc. And Francois Hug, the researcher from France, referenced the first research on this in 2009. And it was this person who showed that when someone's dominant in the medial gastroc, they have hypertrophy of the medial gastroc. So if you look down at a client and they've got a really well-developed medial gastroc, make sure they're doing toe-in lateral gastroc exercises, because unless you're firing all fibers from your triceps psoas, you need to have the medial gastroc firing. You especially need to have soleus firing and lateral gastroc. If they're not all pulling on those tendons, their corresponding tendon fibers, the tendon won't get stronger. That's why 60% of the people with the Alfredson protocol, and this Keith Barr talked about it, prolonged isometric contractions do this amazing thing where if you put a heavy weight on someone and said, drop your heel down and just hold it, especially if the knee is bent, you get this slide of about 11 to 12% where the healthy, resilient tendon fibers slide against each other, and then they expose the tendinopathic tendons to force that stimulates remodeling. You wouldn't get that with the Alfredson. If you were just going up and down, you're just going those healthy fibers are just going to take over and there's going to be no movement. You hold it isometrically and wait 30, 40, 50 seconds. He measured lysyl oxidase, all these other ERK, all these enzymes associated with cellular remodeling. They make crosslinks on tendons that improve strength. And he showed those enzymes peak in 6 to 10 minutes. So you can, after 10 minutes, they're refractory for 6 hours. So if you gave someone an exercise protocol that took an hour to do, and the Alfredson protocol wasn't easy. It was 3 times 15, but for 2 exercises twice a day. It was 180 high resistance contractions. Compliance was low. So another paper showed that if you did these exercises with poor compliance, you still got the same outcome. And the paper that I just wrote on it, I go into the lower the pressure with isometrics, hold for 30 seconds 2 times a day. You could do your standard exercise, whatever it is, once a day, like toe pro, toe in, toe out, or wherever, whether you're doing it on a stairway or whatever. But then when you do your heavy resistance ones, only spend about 3 or 4 minutes doing them and then do them 6 hours later. Because then you'll get that double whammy where you get the enzymes twice a day repairing and remodeling. But, if you don't want to do it, if you're not a pro athlete or you just don't want to put in the time, you don't have to. But the standard protocol, but how many times a week do you do this? That's another thing with exercise prescription. That's why today we were talking about how many stats, what's the dose? And that's up in the air. Nobody really knows.
Yeah, exactly.
I personally feel like elite athletes can tolerate amazing amounts, and I will push them with hard protocols. But older people, I have them exercise daily. I maybe give them 1 day off a week just for the heck of it. But older people, I'll have them do once every 3 or 4 days. And compliance goes up when you say do this twice a week, as opposed to 15 to 20 minutes a day with heavy resistance. Because these protocols, I have people hold weights while they're doing them. You have to have enough weight to force fluid out of the tendon. Right. And that's not easy to do.
That's enough to chew on, I think. I love it. Well, balance buttons, obviously a no-brainer, and then maybe let's start rethinking our Alfredson protocols, some Achilles tendinopathy protocols.
Yeah, I'm doing the illustrations for that next week, so we're going to put that up because you need to see it.
Yep.
And that makes it. And then strengthening synergists. They showed that if flexor hallucis longus is weak, it loads the Achilles tendon, because they did a study. They showed that after Achilles surgery, 12 weeks later, you have hypertrophy of flexor hallucis longus because it has a really good long lever arm to offload the Achilles. So you'll want to accelerate recovery plus offload it while it's healing. And a strong flexor hallucis longus and digitorum longus can do that.
God damn it. Just go buy the freaking Toe Pro and use it. Buy some balance buttons and use them. I'm about ready to run out of batteries. And so we are literally
Literally and figuratively.
Limping our way home.
We are limping our way home. So, Tom, thanks for being amazing.
always a
You're
pleasure.
amazing.
You guys
Appreciate
are
it,
the
guys.
best. Yeah,
thanks
you guys are
again for
great.
tuning in for a great episode. And good luck with patience. We'll check you next time. I hope you enjoyed this episode of the Gestalt Education Show. If you liked it, share it, subscribe to it, send it to your friends, send it to someone that needs to hear this message. We really want everyone to be able to tune in and get the best clinical advice that they can, which we're hoping that we're giving to you with these special guests. So if you have any questions, please feel free to reach out to us, or if you have any suggestions on upcoming conversations, let us know. For a list of our upcoming courses, we're adding them all the dang time. So go to gestaltedu.com, click on courses, and they'll all be right there for you. All right, have a good day.